Welcome to Sir Robert Chiduk Tutorials. Learning is 24/7. Hello and welcome to Sir Robert Chiduk Tutorials. Today I want to look at respiratory tract conditions, and particularly we are going to look at atelectasis or lung collapse. It can be called atelectasis or lung collapse under respiratory conditions. And the book that we are using, we should start by acknowledging the book that we are using. We are using Brunner and Sudath. We are using Brunner and Sudath. We are using Brunner and Sudath. So these are the learning objectives. These are the learning objectives. On completion of this chapter, the learner will be able to identify patients at risk for atelectasis. Maybe let me go straight to atelectasis, which is lung collapse. Let me go straight to atelectasis, which is lung collapse, right? I guess you can clearly see. Now. Right. So what is atelectasis? Atelectasis refers to closure or collapse of alveoli and often is described in relation to X-ray findings and the clinical signs and symptoms. So this is atelectasis. It refers to the closure or collapse of alveoli. Alveoli, these are the smallest functional units of the lung tissue. These are the alveoli where gaseous exchange occurs. So when there's collapse of the alveoli, that's atelectasis. So in simple terms, atelectasis refers to lung collapse. Atelectasis may be quite acute or chronic, and it may cover a broad range of pathophysiologic changes, from microatelectasis, which is not detectable, or on chest X-ray. So this atelectasis or lung collapse, it can be minor or it can be major. So it can be microatelectasis, which is simply loss of a segmental lobe or overall lung volume, right? So it might be a segment of the lung, it may be a lobe of the lung, or it might be overall lung volume which is affected, right? So the most commonly described atelectasis is acute atelectasis, which occurs frequently in the post-operative setting or in people who are immobilized and they have a shallow monotonous breathing pattern. So we found that atelectasis or lung collapse occurs in people who are immobile, in people usually who have been confined to prolonged bed rests, right? These are the people that are prone to lung collapse because there isn't much exercise. They are just sleeping on a bed for a prolonged time and no one cares maybe to exercise their lung tissue, to do breathing exercise for them to exercise their lungs, right? So people that have a shallow monotonous breathing pattern, right, particularly those that have got prolonged bed rest. So we find that it may happen post-operatively after someone after surgery, in simple terms. Why? Because someone is not exercising their lungs enough. So excess secretions or mucus plugs may also cause obstruction of airflow and result in atelectasis in an area of the lung. So you can see another cause of atelectasis again. In this case, we have excess secretions, right? So excess secretions or mucus plugs may also cause obstruction of airflow, right? Obstruction of airflow, which result in atelectasis in an area of the lung. So if there's excessive secretions, these are going to block the free passage of air and result in atelectasis, right? That is obstructive atelectasis in the patient with lung cancer that is invading or compressing the airway. So you can have obstructive atelectasis. So this type of atelectasis is more insidious and slower in onset, right? So in brief, we said atelectasis refers to the collapse of the alveoli or the closure. We said it's simply the closure or the collapse of the alveoli, right? That is atelectasis, and we found that the causes of atelectasis, usually it occurs in people. It occurs to people that are immobilized post-operatively, that is after surgery. It also happens in people that have got excessive secretions, right, that will block the airways, right? And then we also observed that atelectasis, we discovered that the causes of atelectasis, we've got obstruction of the airflow, we have prolonged bed rest, we have excessive secretions. These are some of the causes of atelectasis. Lack of exercise due to prolonged bed rest. So now I want to look at pathophysiology of atelectasis. Let us look at pathophysiology of atelectasis. Atelectasis may occur in the adult as a result of reduced alveolar ventilation. Alright, I want you to be clearly observing. Right, atelectasis may occur in the adult as a result of reduced alveolar ventilation. Right, so reduced alveolar ventilation. That's why we talked earlier on about obstruction of the airway, which leads to lung collapse. So atelectasis may occur in the adult as a result of reduced alveolar ventilation or any type of blockage that impedes the passage of air to and from the alveoli that normally receive air through, right? So anything that blocks the alveoli is bound to cause, atelectasis, right? This is what we have seen. Right, or receive air through bronchi and network of airways, right? So let's proceed with the atelectasis. The trapped alveolar air becomes absorbed into the bloodstream, but outside air cannot replace the absorbed air because of the blockage. So this is what the blockage is going to do. The air which is trapped in the alveolar air, it is simply absorbed in the bloodstream, right? But the outside air, it cannot replace the absorbed air. It cannot enter. Why? Because there is already a blockage. So the first thing, so what is going to happen is that once there's blockage of the alveoli, there isn't going to be any entrance of air into the alveoli, which are supposed to be performing the function of gaseous exchange. So now that becomes problematic. As a result, therefore, the isolated portion of the lung becomes airless and alveoli collapse, right? So I hope you are clearly following. So here we are saying, what we are saying is, because the alveoli have been blocked and there is no entrance of air from the outside into the alveoli, what is going to happen subsequently is that the alveoli are going to be airless, and because they are going to be airless, they are not going to survive. Therefore, there is going to be lung collapse. So they are going to become airless and the alveoli will collapse. Right? Let me highlight here. As a result, the isolated portion, the isolated portion of the air of the airless alveoli will collapse. Right? It will collapse. So the airless alveoli are going to collapse. So we've seen that there's blockage of the alveoli, right? The alveoli become airless, later the alveoli collapse. This may occur with altered breathing patterns, retained secretions, pain, alterations in airway function, prolonged spine position, increased abdominal pressure, reduced lung volume due to musculoskeletal or neurologic disorders, restrictive defects, and specific surgical procedures. Let me try and explain. All these disorders that are being mentioned, they in a way lead to less air in the alveoli through blockage or through partial blockage, right? Let me explain. We are saying this may occur with altered breathing patterns, right? The alveoli will become airless and collapse because of altered breathing patterns. For example, if there are retained secretions, someone has got a lot of secretions in the lungs, right? It means there's going to be blockage. These secretions are going to block the airways, right? It means these secretions are going to block the airways. And when these secretions block the airways, it means there's not going to be entrance of air into the alveoli. So the alveoli, the affected part, will become airless and collapse. And then increased abdominal pressure. If there's also increased abdominal pressure, right? It means that increased abdominal pressure is going to force the outside air outside, and this air is not going to enter into the alveoli, leading to lung collapse again. Then we have reduced the lung volume due to musculoskeletal or neurologic disorders. So musculoskeletal problems, these are problems of muscles, and also the neurologic disorders, right? These are disorders affecting the nervous system. These ones also, they can affect how the lungs perform their function, leading to absence of air in the alveoli and subsequently lung collapse, right? For example, upper abdominal, thoracic or open heart surgery. These are some of the issues as well. Then we have persistent low lung volumes, secretions or mass obstructing or impeding airflow, and compression of lung tissue may all collapse or obstruction of the airways, which leads to atelectasis. So all these are some of the disorders that are blocking the entrance of air into the alveoli. The post-operative patient is at risk for atelectasis because of the numerous respiratory changes that may occur. A monotonous low tidal breathing pattern may cause airway closure and alveolar collapse. This results from the effects of anesthesia or analgesic agents, supine positioning, splinting of the chest wall because of pain, and abdominal distension. So you see that in the post-operative period, when soon after surgery, someone has been taken back from theater, the challenges that we are going to see is that some of the anesthetic drugs, they depress breathing, they affect breathing, so there won't be enough air in the alveoli, which also causes lung collapse. And again, because someone may be having excruciating pain, a lot of pain, they may decide to splint their chest so that they don't aggravate and exacerbate the pain. When that happens, it means that there isn't going to be enough air entering the alveoli because of shallow breathing. And when that happens, what it simply means is that you are going to have lung collapse, which is atelectasis as well. So these are some of the issues which happen as well. Atelectasis resulting from bronchial obstruction by secretions may occur in patients with impaired RAF mechanism, for example, postoperative, musculoskeletal, or neurologic disorders, or in dilapidated bedridden patients. This I have said already, bedridden patients, these are patients being affected due to prolonged bed rest. Atelectasis may also result from excessive pressure on the lung tissue, which restricts normal lung expansion on inspiration. Such pressure may be produced by fluid accumulating with pleural space, for example, pleural effusion, which is accumulation of excess fluid in the pleural space, right? Then we can have pneumothorax, which is blood in the pleural space. That is hemothorax, blood in the thorax, and also pneumothorax, which is air in the pleural space. The pleural space is the area between the parietal and the visceral pleura. We're going to see it in anatomy and physiology, particularly looking at the description of the double layer of the pleura, which is a double layer of serous membrane which invaginates or surrounds the lungs, right? So that was about atelectasis, what atelectasis is, the pathophysiology, its causes, and the pathophysiology of atelectasis. That is what we have seen in atelectasis, right? That is what we have seen in atelectasis. So now it's important for us to know the clinical manifestations of atelectasis. The clinical manifestations of atelectasis. We've seen the pathophysiology, but we need to know the clinical manifestations of atelectasis. The development of atelectasis usually is in seizures. Signs and symptoms include cough, sputum production, and low-grade fever. Fever is universally said it is clinical sign of atelectasis, but there are few data to support this. Most likely the fever that accompanies atelectasis is due to infection or inflammation distal to the obstructed airway. In acute atelectasis involving a large amount of lung tissue with lobar, that is lobar atelectasis, there is marked respiratory distress which can be observed. In addition to the above signs and symptoms, we have dyspnea and tachycardia, right? So these are some of the clinical manifestations that we have with fever, with sputum production, with low-grade fever, with dyspnea, with tachycardia, among other clinical manifestations, with tachypnea, with pleural pain, with central cyanosis, which is a bluish skin color that is a sign of hypoxemia, right? So these are some of the clinical manifestations that we have, right? So thank you so much for today's lesson. Until next time.